Good evening, and thank you, Ms. Fontaine. Thank you for taking the time out of a busy day to learn a little bit more about headache. Hopefully, this won't be repetitious, and hopefully, there'll be something that can give you information that you can use for yourselves and for those of you who have folks that are suffering from headache. Um, First of all, just to go through the disclosures, I have nothing to disclose. I don't have any pharmaceutical industry connections or any other industry connections. I'm relatively new to Baystate. I've been here now just under 3 years. I used to be at Boston University Medical Center, which is this big, huge complex here. And I used to direct the pain and the headache clinic there for about 25 years. We saw pretty much everything. And I thought that when I came out to Baystate, things would be a little bit easier. But it turns out that actually we have an incredibly complex number of patients with headaches and other neurological disease. And I really have been able to recruit more neurologists from Boston Medical Center to join us at Baystate to help us with these patients because don't realize this, but Baystate is really the only major referral center in the area, and the number of patients that we're covering is essentially the same number of patients that 6 teaching hospitals cover in Boston. So we're seeing a lot of things that used to take me years to see, and I have to say I'm delighted to be at Baystate and be challenged every day by the patients that I see. As you can see, Baystate is also a very big place, and it's actually bigger than Boston Medical Center, twice the size. As you can tell from this picture, it's the weather is much nicer and clearer out here in Springfield. Of course, I think we'd all rather be here on this nice, comfortable beach and enjoying ourselves. But for our headache patients, that's really sometimes not an option. And there's nothing worse than having a nice day planned ahead of you and then losing it because you have a migraine. And I think that that's a big problem for a lot of doctors. They don't understand that migraine is actually as debilitating as it is. And for folks who don't have migraines, I think they don't understand how debilitating migraines can be as well. I have to say, I have rare migraines. I haven't had one in over 10 years now, but the last time that I had a migraine, I was pretty much out for the count. And I actually had to have a colleague take my call. So believe me, I sympathize when I hear my patients complaining about migraine. So what are we going to talk about tonight? We're going to talk about the different types of headaches. We're going to talk about what your doctor should think about when you go to them thinking about the type of headache that you have. What type of headache is it? What else could it be? And then how we go about trying to figure that out. What's the approach to our diagnosis? And then we're going to go over the medical treatments and also other approaches that are available for headache management for some of the more difficult cases. How big a problem is it? Well, chronic daily headache affects about 5% of the US population. That's about close to 16 million people. 16 million people have a headache every single day. Those folks account for about 20% of the telephone and message calls in our clinic. And if you look at the amount of money that's spent on headache and migraine management, including emergency room visits, diagnostic testing, and direct medical care, it actually costs more than care for stroke and heart attacks combined. That's a staggering number of dollars that are spent on something that's thought to be pretty benign. And headache is not something that people learn a lot about in medical school. And, there's your doctor trying to figure out what it is that you've got, and you are trying to figure out what you've got. And the two of you should be taking this road together, but sometimes the road diverges. Is it migraine? Is it tension headache? Is it sinus headache? And then what kind of treatment am I going to get for this? So I try to break it down into three major categories. And this is kind of like how headache doctors think about headaches in general. We talk about primary headaches, and those are headaches that are due to actual problems in the nervous system itself. Migraine is the classic example of that. Tension type headache, which is much more common than migraine, is also thought to be neurological in origin. There are these rarer headache syndromes called cluster, is probably the one that you're most familiar with. They fall under the category of trigeminal autonomic cephalalgias, which is doctor speak for their headaches that affect the face and also have associated with them other symptoms suggestive of the autonomic nervous system or your fight or flight response system being involved. And that will include redness of the eye, swelling of the face, tearing, runny nose, and also occasionally redness of the ear. And that's part of your fight or flight response. And that nervous system component is what seems to be the actual trigger. And that's very different than migraine and tension type headache. They're difficult to treat, but fortunately, they're fairly uncommon. And then there's a whole slew of other very unusual headache syndromes, cough headache, ice pick headache, a whole slew of other very unusual headache syndromes. And one of my favorite ones is called hypnic headache, which is also known as alarm clock headache. And it's a headache that wakes people up every night at the exact same hour, usually 2 to 3 o'clock in the morning, to the point where folks say they feel like they have an alarm clock that's waking them up, pounding on their head. Those are a very unusual type and very rare headache syndromes, but they are something that headache doctors are familiar with and for which there is treatment. Secondary headaches are headaches that are due to other medical problems that lead to headache. Obviously, trauma, hitting your head is certainly a big cause of headache. Stroke, increases in pressure inside the skull itself, substance use. Probably one of the most common causes of headache is overuse of medications, particularly over-the-counter medications. The stuff that they actually put in the pills to hold the medication together can actually produce an allergic reaction in some people that leads to headache. Coffee-related headaches are a substance-related headache. There are folks who, drink 2 to 3 cups of coffee every day at work, but they don't drink as much coffee on the weekend, and they get severe headaches on the weekend as relative caffeine withdrawal kicks in. There are headaches that are due to changes in chemicals in your body, sodium, potassium, sugar levels, etc., all can produce headaches. And then psychiatric issues, certainly depression, anxiety, fear can all produce worsening headaches. And then there are things that are lumped as headaches, but are really not headaches. They're due to irritation to nerves that supply your face and your skull. So when people have what's called a Bell's palsy, a facial droop, they can have irritation of the nerve, and that can produce some head pain, but it's really not a headache per se, but it's another thing that headache doctors deal with. We're not going to talk too much about that, and that also includes things like trigeminal neuralgia or tic douloureux. They're a topic for another day. So when you are looking at all of these headaches, it can look like one big lump of stuff, but there's actually really pretty good ways that you can differentiate them. So here's a slide to kind of give you an idea of the differences between the most classic cluster type category of headaches, and then migraine and tension type headaches, which are by far the most common type of headache that you see. So, in a typical headache population, about 80% of patients have tension type headache, and 15% have migraine, and less than 5% have the trigeminal type headaches or cluster. So, tension type headaches, will start off on the left, can come on at any age. Men and women are equally affected. The key here is that the intensity of the head pain is relatively moderate. It can be pretty bad when you have it, but you can continue to work and do what you're doing when you have one of these tension type headaches. And the clue is that if you go up and down the stairs, the headache may get a little bit worse, but it's not going to drive you to your knees and into a dark room. So when patients come to the office and they say that they have migraine and I have neon lights flashing above in the ceiling and they're able to talk to me and give a very clear and coherent history, chances are this is probably not an actual migraine attack, but really more a severe tension type headache. The other thing is that there are no other systemic signs with tension type headache. People may get mildly nauseated, but they don't throw up. They might be mildly sensitive to sound, but they don't have to plug their ears. They may be sensitive to light, but they don't have to lie in a dark room. And they may be sensitive to smells, but they don't have to run away from any type of smell that comes their way. All of those things may be irritating, but they're not debilitating. In contrast, migraineurs, when they have a migraine attack, can't stand any external stimulation. They're very sensitive to light, they're very sensitive to sound, and they're very sensitive to smell. They may have one-sided type headache, but that's not necessarily the case. Only 40% of migraines are one-sided. And you can have lots of tension headaches that are one-sided, that mimic migraine, especially if you have neck spasm on one side. We always look for nausea and vomiting in migraineurs, and we look for inability to continue to function. And we don't even have to ask that question most of the time. People volunteer that. They say, oh, I know it's a migraine because when I get it, I just have to lie down and turn everything off and crawl under the covers. You don't hear that from tension type headache patients. They'll tell you that they're miserable. They sometimes have to leave work, but they can usually continue to function. Cluster headaches and trigeminal cephalalgias are very different. Their pain is thought to be among the most severe of all pains. It's usually stabbing. It's usually in the eye, in the orbital area. And patients are very restless and agitated. I've had patients bang their head against the wall to try to make the pain go away. They tend to get redness of the eye, tearing, they get nasal congestion, and sometimes they'll get eyelid swelling and even ear swelling. That's a very unusual type of situation. And in comparison to migraine, where women are affected much more than men, in cluster, it's much more men than women. In fact, it's exquisitely uncommon to see cluster in women. Other things that you see that differentiate migraine from tension type headaches is tension type headaches can run the gamut from 30 minutes to an entire week. Migraineurs tend to have headaches that last hours to days. They rarely run into an entire week. Tension type headaches tend not to be periodic, whereas migraineurs may be sometimes prone to periodic headaches, particularly when it comes to menstrual migraines. Cluster headaches are very periodic. They tend to occur seasonally. They get multiple attacks during the course of the day, and people can almost set their calendar to when they're going to have a cluster attack. Tension type headaches are triggered mostly by stress and poor sleep. Migraine headaches are triggered by a variety of things, including dietary changes, alcohol, hormonal changes, dehydration, and sleep deprivation as well. Cluster headaches are triggered mostly by alcohol and histamine release. And you can kind of see that pretty regularly, especially with the seasonal character of cluster. Why do these things happen? Well, on your left, you'll see a slide that has those yellow twigs, and those are actual nerves sitting on a blood vessel. And those nerves come out of the nervous system, out of the brain, and go through a variety of paths and end up on the blood vessels covering the coverings of the brain, the meninges. For reasons that are unclear or probably much more complicated than we understand right now, there are electrical discharges that occur in this area here of the nervous system called the trigeminal nucleus caudalis, which is the lower part of this part of your brainstem. And that sends signals to upper parts of the brain and also out into the nerves themselves. When the signals go out to the nerves themselves, the nerves release inflammatory substances. There's nothing to trigger the inflammation other than what we think is an electrical discharge in your nervous system. The inflammatory substances cause your blood vessels to react. There is irritation of nerve fibers that carry pain at the blood vessel level, and that information goes back to the nervous system, causes a rebound signal to come back out, and becomes a self-perpetuating cycle. And that becomes then the onset of the migraine. We think that this is what occurs in migraine with aura, and we think it also happens in migraine without aura. Tension type headaches, unclear exactly why that happens, but certainly there is firing in this part of the nervous system as well, but it doesn't seem to be associated with inflammation at the blood vessel level. Now, because we know the chemistry of migraine, we can actually develop medications to try to block some of these inflammatory actions that occur at the blood vessels. And the chemical which we try to block is a chemical called serotonin. That's sort of your feel-good neurotransmitter. For those of you who've heard of triptans, which are the mainstay of treatment for migraine, triptans were specifically developed to block serotonin at the blood vessel level. And that's how they work. They block it here, and they also block it at the central nervous system. And that can be very effective for most patients in terms of aborting their attack. These were actually tailor-made molecules to block a specific neurotransmitter at a specific site. And that's actually really pretty amazing that we have the technology to be able to do that. They don't work for everybody, and they do have side effects, but when they work, they're really very effective. Newer drugs have been developed, and you've probably seen them advertised on television. They're called anti-CGRP monoclonal antibodies. They're actually antibodies, just like the antibodies that fight infection, that have been developed against a particular neurotransmitter called CGRP. And if you remember, CGRP is one of the chemicals that's released at the blood vessel level that causes inflammation and leads to pain. So by directing an antibody to sort of cover and block CGRP, we can actually stop migraines from developing. And there are two classes of anti-CGRP antibodies, and we'll talk about them in a little while. So what else could it be when you have a headache? What happens if you don't fall into the migraine category, and you don't fall into the tension type category, and you don't fall into the cluster category? Well, the first thing that your doctor should think about is that the diagnosis is wrong. Either you were diagnosed as having migraine, but you have tension type headache, or you have tension type headache and you were diagnosed with migraine. You got to go back and forth. You may also be looking at secondary causes. Was the imaging done correctly? Is there an infection going on? Is there some other illness happening? And that's the first thing that you want to make sure that you don't miss. You also want to make sure that you don't miss other medical problems that present with headache. Probably one of the most common ones that we see in our clinic is sleep apnea. So obstructive sleep apnea is kind of very common nowadays, and we're much better at picking it up than we used to be. The reason why you get headache with sleep apnea is, first of all, you don't sleep. And second of all, your brain doesn't get any oxygen. And that's really a trigger for inflammation. So obstructive sleep apnea is really critical to pick up early on in the ballgame because a lot of the medications that you use can actually make sleep apnea worse. And that sometimes is the reason why people have not been able to be treated successfully because they've been tried on a lot of medications. But what's happened is that they had sleep apnea in addition to migraine, and the apnea became worse. And as a result, their headaches didn't get any better. Another situation is something called low pressure headache. That can occur after trauma where people can have a spinal fluid leak. For anybody in the audience who ever had an epidural and then had a leak afterwards, these are very postural headaches. They get worse when you stand up or sit up, and they get better when you lie down because the pressure goes up when you lie down. We see this occasionally, especially in people who've had falls or who have had procedures, and it can be treated very effectively. The opposite of low pressure headache is high pressure headache, and that's called idiopathic intracranial hypertension, and it's also known as pseudotumor cerebri. That can occur in a variety of settings, including obesity, sleep apnea, certain hormonal disorders, and it usually shows up with a headache which is worse when lying down, which wakes people up in the middle of the night, and is associated with visual changes. It's usually picked up by optometrists and ophthalmologists who see pressure behind the eye. And the optic nerve, which is what your doctor is looking at when they look at your eye, is actually naked part of the brain hanging out through your skull. And it's really the only part of the nervous system that you can examine directly. And if there is pressure within the skull, that pressure is transmitted into the part of the brain that you can see in the back of the eye. And that's called a swollen optic disc or papilledema. And if you have that, that's sort of something that really needs to be dealt with pretty quickly because untreated intracranial hypertension can lead to blindness. And there are very effective treatments for this, and we do see a fair amount of it at Baystate. And we manage these patients with medications. Occasionally, they may require surgery. Another common cause is unrecognized medication overuse. People take over-the-counter medications all the time. You have a bad headache, you want it to go away, you're going to take something, and then you keep taking it. The problem is that those medications can actually lead to headache, and that becomes really difficult to manage. Medication overuse headache is really difficult to treat because it requires that the person stop taking something for their headache. And that's really hard to do when you're in pain. So there are tricks of how to deal with that, but the fundamental thing is basically to detox from the over-the-counter medications. So that includes acetaminophen, ibuprofen, naproxen sodium, in all of the sort of proprietary forms like Anacin, Excedrin PM, and so on. It doesn't make any difference which one it is. They all end up doing the same thing. Other sleep disorders can present with headache because you're not getting any sleep. So restless leg syndrome, periodic leg movements, and there's a whole slew of other weird sleep disorders that require additional examination. And then finally, mood disorders. People ask about the weather. The weather, I can tell when I'm going to get a migraine, and I can tell that it's going to happen because the barometric pressure is changing. There's actually studies that show that that is in fact true. The problem is, I'm just a doctor. I can't control the weather. None of us can. So we have to deal with that. And sure, you can predict that that's going to happen, but there isn't really very much else that you can do except move to a place where the barometric pressure doesn't change very much, which would probably be Antarctica. That's the only place where barometric pressure doesn't change except seasonally. There are certain things that are marketed supposedly as helping folks that have barometrically determined headaches, but they don't really have any proof to support their use. I tell people to try them. They're basically earplugs, but the mainstay, even for barometrically triggered headaches, remains medical management. I'm going to give you a case of a patient who is an example of what happens when people have strange things happen to them and you don't think about it. And this was a patient that I actually saw a number of years ago. She is a 28-year-old woman who had childhood meningitis and had some residual deafness. She was working at a bank. She was very successful. And she was referred because she had had chronic daily headache for 4 years. She had failed multiple medication trials. She had seen multiple neurologists, including people at headache centers in Boston. She had been treated with Botox, and she had had negative brain imaging and blood work. She was seen by psychiatry who didn't think that there was a psychiatric issue. And I saw her and I kind of went through things again, wasn't really sure where to go with her. When she called me from London, and she told me that for the first time in 4 years, she hadn't had a headache. And I said, well, that's weird. Like, why? What happened? She said, well, it was an overnight flight, and I decided I didn't sleep because I was talking to my boyfriend on the plane, and we got there, and for the first time, I didn't have a headache. I said, well, that's really weird. Obviously, sleep has something to do with your headache. When you get back, we're going to do a sleep study. And we did a sleep study on her when she came back, and sleep study was totally normal. So and then the headaches came back and didn't really know what to do with that. And then one day she came in to see me for a routine visit. And she said, by the way, can you take a look at the back of my throat? Because I think I have a sore throat. Well, this is what she had. And I said to her, gee, I don't remember that you had a tongue piercing. And she said, oh, I have a tongue piercing. I said, well, how long have you had a tongue piercing for? She said, I've had it for about 4 years. I said, did you have your tongue piercing when you had your sleep study? And she said, oh, no, they told me they were going to video me, so I took it out. Now, I didn't know that you could take tongue piercings out. I thought they were pretty permanent, but she used to take it in and out because she didn't wear it at work. So we repeated the sleep study with a tongue stud in, and guess what? She had profound sleep apnea because her tongue fell backwards and closed her throat. And that was the reason for her chronic headaches. I got lucky. I saw her throat, I put it together, and we made the diagnosis. But this is the kind of problem solving that you have to do when you have patients who have difficult to manage headaches, and we do it all the time. So that's why we take nothing for granted. We try to confirm as much as possible. We do some blood work, mostly thyroid function tests. And we spend a lot of time reviewing medications, including supplements, over-the-counter things that are thought to be all natural. We take meticulous caffeine intake history, how much water you drink, what type of food do you eat, and so on. And that's really important for us to try to make sure that we don't have things that we're missing that are contributing to the headache. What about imaging? We don't generally do imaging on first pass, and there's a reason for that. MRI scans are super sensitive, but they're not specific. Most migraineurs will have little signal changes in the MRI scans that we see a lot and have no clinical significance. But part of the interpretation from the radiologist will be that this could be seen in multiple sclerosis. And that means then that we have to repeat the MRI scan in 3 to 6 months to show that there haven't been any changes in those signals, which they never are, but unfortunately, we're obliged to do it. So the American Academy of Neurology actually does not recommend doing MRI scans in people who have classic migraines because they tend to confound the diagnosis. And I would tell you that we see a lot of patients who have these sorts of MRI scans done by their primary that we basically have to repeat the scan in 6 months for no good reason. We do sometimes do lumbar punctures for pressure measurement, and if those are abnormal, then we have to do additional imaging to see why that might be. And at Baystate, all the lumbar punctures are done under X-ray guidance in the hospital. So what are the strategies? First of all, you start with lifestyle interventions. You try to reduce stress. You try to get better sleep. You try to eat healthy. We have to put into place acute treatment for the acute migraine and then preventative treatment to decrease the frequency. And the rule of thumb is that if you have more than 4 migraine days per month, you probably should be on preventive treatment. And then we also give people rescue treatment so that they have something that they don't end up in the emergency room if acute treatment and preventive treatment don't work. And with acute treatment, the goal is to give you rapid relief, restore function, and reduce life disruption. Sure, it should be cost effective and minimize side effects, but these acute migraine drugs are very expensive and can be difficult to use. But the main thing is that they have to be effective and they have to get you back to where you want to be. And these are the drugs that we use. We use multiple triptans. And by the way, sorry, this is sort of doctor code here. Level A evidence is evidence that's developed by this sort of gold standard for drug studies, double-blind, placebo-controlled crossover studies, so that you're comparing drug to a placebo and everybody's blinded and you don't know who's getting the active drug so that you can see true effect. So all triptans have been found to be effective. There is something called dihydroergotamine inhaler, which is also available for patients that can use nasal sprays. All the anti-inflammatories are helpful. Acetaminophen can be helpful. And more recently, drugs that are called GPANTs, which are those anti-CGRP antibodies. Second-line drugs, which are also effective but not as convincing, are anti-nausea medications, metoclopramide and prochlorperazine. And these are the kinds of things that you might get in the emergency room during an acute attack. Intravenous dihydroergotamine, which has been around since my dad was a neurologist, and really can only be given on an inpatient setting. Ketorolac, which is an intravenous anti-inflammatory, and then less likely to be effective, occasionally opioids. We don't recommend opioids because you develop tolerance to them. I certainly have used opioids for patients, but they are very, very much my last choice. For preventative medications, we have lots of different categories, and they kind of fall into 3 main categories: anti-seizure type drugs, beta blockers, which are used for blood pressure control, and anti-CGRP antibodies that are long-acting. And these are the various drugs that we have available. And these are the ones that have been found to be the most effective: divalproex or valproic acid, topiramate, propranolol, and then the anti-CGRP drugs, arenumab, eptinezumab, praminezumab, and galcanezumab. There's pretty strong evidence that these drugs work as well, but no studies have been done per se, but there are multiple studies that show that these are a benefit. Amitriptyline and venlafaxine, these are both antidepressant type drugs and a different type of beta blocker. And then these are sort of unusual drugs on their own. Cyproheptadine is a very powerful antihistamine that crosses into the brain, unlike other antihistamines. These drugs, there's really very little evidence that they are effective, and that includes gabapentin, protriptyline, and calcium channel blockers. Occasionally, people also have to be admitted to the hospital to be detoxed, and we do that at Baystate. That's kind of a big deal, and we reserve it for patients that have had headaches for 10 days or more and can't really keep things down, and it's the only way that we can get them to break the headache cycle. Botulinum toxin is also FDA approved and very effective for migraine control. We talked about anti-CGRP drugs, and then there's also nervous system stimulation, which is an emerging form of therapy. A couple of words about Botox. No one really knows exactly how it works, but it's been around since 1995 for spasticity use, and it was approved in 2004 for migraine use. Initially, it was not thought to be effective, but there have been so many trials looking at botulinum toxin now that it is very effective with more than a 15% reduction that's sustained over 3 months in migraineurs. What about your tension type headache situation? Well, we do use a lot of the medications that we use in migraine, but in different doses, and we use them to maximize sleep. But the mainstay of treatment for tension type headache are lifestyle modifications. And I would focus mostly on regular sleep. It's amazing to me how difficult it is for some patients to get normal sleep. Everything from having animals jumping into the bed to having difficulty with bladder control. This is really, or most commonly, undiagnosed sleep apnea. There is specific treatment for insomnia with cognitive behavioral therapy, and we do refer people for that to behavioral health. Exercise, meditation, and mindfulness are keystones for stress reduction. Stress reduction is really the mainstay of treatment for tension type headaches. And sometimes that requires medication, but medication alone is usually insufficient and is going to require a behavioral component. What about other treatments? This is a head stimulator, an electrical stimulator called Cephali. It's branded, so I can use that name. It's the only one of its type. It's FDA approved for headache management. It costs about $600. They won't take it back if it doesn't work. My feeling about that is that if you really think that something works, you should be willing to take it back if it doesn't. I don't think it's fair for people to spend $600 and find that it didn't work for them. Their success rate is about 25-30% reduction. Placebo response is 30% in headache studies, so that's not really very impressive. Cannabinoids and CBD oil, word two about those. They clearly improve sleep. Interestingly, they were the specific treatment that was recommended by one of the fathers of modern medicine, Sir William Osler, in his first textbook of medicine in 1892. And in fact, Sir William, who had moved to Canada later on, made fun of American doctors for taking hemp off the pharmacopoeia. I have no particular axe to grind either way, but I do believe in science, and science says that cannabinoids do help improve sleep without changing sleep architecture. And they have been found to be, quote, potentially useful in at least two guidelines, one from the European Pain Federation and the other from the Canadian Agency for Drugs and Technology and Health. So our friends across the pond and up north do actually use these. And you use them judiciously, just like every other drug. So when it comes to treatment, the main thing is to try to get everybody who's going to be involved in treatment to understand what it's going to take. It isn't just a pill. It isn't just one shot. It isn't going to be one nerve block. You have to lay out all the options. And then once you've laid out all the options, you need to understand that it isn't just me who's going to tell you what to do, but it has to work for you. You have to feel comfortable with the treatment, and you have to be willing to accept a certain degree of side effects initially that we can then try to alleviate by switching timing or dosing of medication. And then once we talk about all of that, we come to a plan that works for both of us, and then we implement it, and then we see how you do. And then we decide if we can do better. I have so many patients say to me, Dr. Otis, can't you treat my headache without medications? The answer is yes, I can, but I'm not going to be very effective at it. By the time that you're coming to see a neurologist, by the time you're coming to see a doctor, chances are you've already tried the non-medical route and it hasn't really worked for you. So some medications are going to be needed. I understand nobody wants to be taking medications if they don't have to. And if you read the side effect profile of every drug that is given to you, you would never take medication. I tell my patients the most common side effect of laxatives is constipation. So you can't believe everything that comes out in those descriptions, but you have to trust your doctor, and you have to trust that doctors don't get up in the morning and think, I'm just going to give my people poisons. We really do think very seriously about the side effects, and we try to go over those with you, and we try to manage them as best as we can to try to find out something that works the best for you and which is acceptable for you and gives you the best relief. And in the end, this is really what it's all about. The day that we used to sit at the bedside and watch our patients suffer while the families were waiting for us to do something, and the only thing we had here was tincture of opium, are long gone. We really do have a lot of things that work very effectively, I would say, for more than 90% of our patients. If you listen to your patient, you can come up with the exact treatment that works best for them, and they're going to tell you what is wrong with them and give you the clue that you need to treat them effectively. Thank you. I hope that was helpful. I'm more than happy to take questions. Ms. Fontaine, I guess you're going to be moderating that.
Yes, thank you, Dr. Otis. That was fantastic, and I learned quite a bit. Really terrific. Thank you for preparing that talk. We do invite our attendees to put their questions in the Q&A box. And so Lauren has a question. She said or asked, does Baystate offer Botox for migraines? Would you recommend it?
Yes, we offer Botox for migraine. I've been doing Botox for many years, and we do Botox regularly in our clinic.
Excellent, thank you. Marianne, would like to know, is there a connection between gluten diet and headaches?
That's a really good question, and I'm gonna start by saying I'm not trying to hide anything here or fudge my answer. It's just the answer is not really clear. There are people that are gluten sensitive, and there are people that are gluten allergic. And I think one of the problems is that it depends on how you look at it. If you're a gastroenterologist, you're looking for somebody who has sprue and has, GI symptoms and diarrhea and bloating and so on from gluten. If you're a neurologist, you know that gluten can produce autoimmune reactions to the nervous system. And some of them can be really spectacular, and others can be much less subtle, much more subtle. So gluten-free diets are kind of used as a last resort in people in whom nothing else seems to work. If you really look at the studies, the results are mixed. I suspect that there are a few people that really are gluten sensitive, and as a result can't tolerate it. And when they go on reduced gluten or gluten-free diets, they do a lot better. How common is that is unclear. It's very difficult to be gluten-free, to really, really do it. People do it. I can give you anecdotally the case where I had a patient who she said to me, every time I eat pizza, I feel like I'm going to explode. And I said, well, is it the cheese or is it the pepperoni or what do you think it is? She goes, I don't really know, but every time I eat pizza, I really do that. I said, well, why don't you try cheese separately? And it wasn't the cheese, and it wasn't the sausage, and it wasn't that. I said, well, you know what? If you really think that it's pizza, try a gluten-free pizza. And he goes, I hate cauliflower crust. And she said, I'm like, well, try it anyway, because you tell me every time you get, pizza, your head explodes. So, which by the way, I've never seen anybody's head explode. I just want to say that that's a very bad medical expression. But anyway, her head was really in bad shape. And so she came back and she said, it's funny. I did try that lousy cauliflower pizza and I didn't get a headache this time. I said, well, maybe you are gluten sensitive. And she said, well, it's funny that you say that because my cousin went gluten-free and her headaches disappeared. So we tested her for gluten sensitivity and she was borderline positive. So it is possible. But I also tested lots of people who were convinced they were gluten sensitive, and it had nothing to do with gluten. It had to do with preservatives and other things like that. So I'm not trying to hide an answer from you. I'm just saying it's very difficult to tease out. We do recommend it for people as a last resort to see if they get better as a result of that.
Lauren would like to know, have you heard of people getting daith piercing in their ear and it being effective?
I heard something about piercing.
Oh, yes. Sorry, let me repeat it. Have you heard of people getting a daith piercing in their ear and it being effective?
I have heard of it. I cannot tell you that studies suggest that it is effective.
Okay, great. So Connie, she's had some headaches for 3 months. Her first MRI said she had a brain tumor. Second one with contrast said that she has vessel disease and she has an appointment in September. And she's wondering if she should wait that long.
I heard that there was a question of a tumor.
Yes, she said that she had, her first MRI said that she had a brain tumor, and the second one with contrast said that she had vessel disease. And she has an appointment with a neurologist in September. Should she wait that long?
I can't answer that question. I don't have enough information to explain, to weigh in on that. Yeah. But whoever ordered the MRI scan should know what the tumor showed. And should direct her accordingly. At Baystate right now, we're reviewing every single consultation that comes in, so it would be seen by a neurologist. And then certainly if we thought somebody had a tumor that needed to be seen earlier, we would do that. I would tell you that right now in the United States, there is a tremendous shortage of neurologists. And in fact, it's almost impossible to get an appointment to see a neurologist, even in Boston, for 16 to 18 weeks. Right now, Baystate is as far as I know, the only hospital that's still taking on new patients. even from within the community. So September may actually be the earliest that somebody can see her. But if she's concerned about whether that's not good enough, that's something for her to discuss with the person who ordered the imaging, and to have that person advocate with her with a neurology practice to be seen.
Thank you. Appreciate that. It looks like there isn't any other questions. We can give it another second. And it sounds like you're needed at the hospital too. So
No, that's okay. We're good.
all right. Well, okay. Well, thank you. We'll just give it another couple of minutes. Really fantastic talk, though. I really learned quite a bit. It's amazing about the eyes that you'd mentioned and all the treatments that you provide. Really fantastic.
Yeah, actually, we provide all the treatments that are used for migraine and headache at Baystate. That was part of my deal when I came to Baystate, was to create a comprehensive headache center. The only thing we have difficulty with is the behavioral component, but we seem to be working on that. And in fact, one of the new doctors who's going to be joining me is also headache trained.
Wow, that's wonderful. Well, we're very lucky to have you. So there, one last question then. Lee would like to know, are you aware of any old-fashioned remedies that work for migraines?
I don't know how old-fashioned. Feverfew is an herb which has been found to be helpful for migraine. It works in about 25% of patients. It essentially contains salicylic acid, which is aspirin. So you would expect that it would be helpful. It doesn't work dramatically for prevention. Vitamin B6, which is riboflavin, and magnesium are over-the-counter things that can be helpful in preventing migraines in about 40% of people, but they're not, they don't eliminate them 100%. They're found in old compounds that used to be used by doctors that were branded and sold over the counter back in the old day. But they're not available that way anymore, so you have to buy them individually. Old things like putting vinegar on brown paper and putting it on your forehead, I don't think there's any literature to support that. I'm not really sure that I know too many other old school remedies for treatment either. But the best treatment is really old school, getting good sleep, exercising, and staying healthy in other ways. Really makes a huge difference. Just as an aside, many people don't realize how terrible their sleep is until you actually start talking to them. And, people tell you, I sleep great. I sleep 10 hours. But do you feel rested when you wake up in the morning? Well, no, not really. Well, then you're not sleeping. Or somebody who gets up 3 times in the middle of the night to go to the bathroom, and you're not getting real sleep at that point. You're only taking naps for 2 hours at a time. And that has a huge impact on headache. So I guess those are my old school recommendations.
Fantastic, Dr. Otis. We're at time, but I want to thank you so much for this great presentation.
Thank you. Those were great questions.
Appreciate your time and expertise. Have a great evening.
Stay well, all.